So I've been dabbling in the stem cell arena for, oh gosh, about 9 years now. Started out with I was with a clinic for about 1.5 years, and then that wasn't such a good fit for me. But that's where I got introduced to stem cells. I was very skeptical at the time. And my first patient there turned out to be an MD. Walks in the door, and that's just the way the schedule turned out. She was a pathologist, did all the research, and there I am. I knew all the techniques, but very first live patient doing stem cells. So we did the stem cell PRP combo. 6 weeks later, she comes back for her PRP booster, and I'm almost afraid to go in and talk to her, you know. So anyway, I go into the exam room, and she's just smiling like ear to ear. Very happy. At 6 weeks, you don't always see that result where usually, so there's two sides to the stem cell coin. One is the regenerative medicine side, but also a very potent anti-inflammatory side. So at 6 weeks, we were definitely seeing the anti-inflammatory benefit. But that very moment kind of flipped the switch for me. I was very skeptical, started really digging into it, and from there, eventually left that clinic and joined Pro-Alliance. Dr. Neil Schauner, one of my Pro-Alliance brethren, sitting right there. Anyway, it's been very interesting, very dynamic field. I do all kinds of interventional pain medicine, but this is definitely kind of an exciting area. So I apologize for the slide here. You should never apologize when you give a talk, but that slide with that clip art is that's kind of a cliche. It's you know, I've been giving this talk for several years now. But anyway, it is what it is. So I felt bad about that, you know, the cliche slide. But then Laxman Chikani, he's the ASIP, was he president for life for ASIP or something like that? Anyway, he comes out with this book several years ago. He's got the same clip art on. I mean, the guy must be worth a fortune, right? And he's got the same thing on him. So I don't feel so bad about using that. I'm in a practice called Pro Ortho in Kirkland, Washington, which is across the lake here. I'm the pain guy. We have about 14 orthopedic guys, and I'm the designated pain guy. So go a little bit of historical context here. Alexander Maskhimov, 1908, proposes the term stem cell for scientific usage. Then we have things like prolotherapy, orthobiologics. Arnie Kaplan comes out with this term, mesenchymal stem cell, and in 1991, this gentleman, William Heseltine, in regenerative medicine, comes out with that term. Arnie Kaplan comes back in 2017 and says, we should really call them medicinal signaling cells. And because of the mesenchymal stem cell thing he thought was a little misleading. The idea that maybe the progenitor nature of stem cells is a little misleading for most people, that maybe they don't all transform into chondrocytes or muscle cells or tenocytes, that maybe it's a little more. So the idea with the medicinal signaling cells is these stem cells actually act like general contractors. They go into say, a joint space, and they start sending out work orders to the surrounding tissue. So anyway, that's an area I think is still a debatable area. Dr. Philippe Ernigoux, orthopedic doctor in Paris, France, or outside of Paris, France. He's kind of the father. He's been doing orthopedic stem cell injections since like the early 90s. Still publishing. So that's the guy, and he's a bone marrow guy. We'll get into that a little bit later. So stem cell, unfortunately, is just that's the term we're stuck with. I think it's got some loaded implications. I prefer the term cellular therapy, but in popular culture, people, you say stem cell, and that's kind of what they can relate to. Going back in the popular press, Time magazine, they've had like 4 different covers on stem cells. I'm just bringing up 2 of them. This goes way back. You can see Condoleezza Rice up in the right-hand corner. That obviously goes back a few years. This was just last year. I think the Wall Street Journal came out with this. Knee or hip replacement without surgery. It's on the horizon. So this comes up periodically with the lay press, kind of fueling the fire, if you will. Oh, here's Arnie Kaplan's article saying, mesenchymal stem cells, time to change the name, where he wants to do it, change it to medicinal signaling cells. It was a nice try, Arnie, but the cat's out of the bag. We're stuck with that term stem cells, as I see it going forward, with all the baggage it has with it. This is just a little, it's a page out of Knox's book about just the research going on in stem cell therapy. You can see how it's just kind of taken off there, and about 2005, all of a sudden, we've just got tons of articles being published with regard to stem cell research, starting by 2005, worldwide, not just in the U.S., but all over the world. Growing number of hospitals and healthcare systems that are purportedly doing some sort of stem cell therapy. We've got the Mayo Clinic, Cleveland Clinic, Emory Health, Yale. These is just a partial list. Swedish hospital, locally here in Seattle. Basically, when it comes to musculoskeletal, I mean, it's pretty much the whole body is in play, right? So, and I've certainly seen results, the major joints for sure, shoulders, hips, knees, but even like the joints in the hands and feet, remarkable how well generally this works. Doesn't, no guarantees in life, but as I tell patients, but for arthritis, I would say that not just my feeling, but a lot of people in this space would say that the only somewhat comprehensive treatment for arthritis is stem cell therapy. The idea being that the lack of stem cells is what contributes to arthritis. When we're young, we have stem cells throughout our body, and but in our joints, it's a dynamic space. It's not like you're just sitting there like, something that's never changing. It's the joints are a dynamic situation with cells dying and being reproduced and regenerating. When we get to a little certain age, maybe, who knows, 40s, 50s, those stem cells in your joints don't keep up, and you get an overabundance of something called senescent cells, and you get arthritis. Now, I'm obviously highly simplifying the whole concept, but that's kind of basically what's going on. So all the other arthritis treatments that we have kind of nibble around the edges. NSAIDs, for example, been around forever, ibuprofen, etc. And that does treat arthritis. Concerns are for long term that those are actually harmful, that they may, over time, accelerate arthritis. There's some research coming out in that area that's fairly compelling. I'm going to talk a little bit about the FDA, because that's important, because they are the ones who make a lot of these rules. And it's debatable whether they actually have jurisdiction over this whole situation. We'll talk a little bit about that. This is just from I think July. This California clinic wins a case against the FDA called the Bernal case. So the Judge Bernal sided with the physicians. They said, the FDA really doesn't have any jurisdiction over us. We're beholden to the California State Medical Board. What we're doing is medicine/surgery. Well, the FDA really doesn't have a role here. So, and Judge Bernal actually supported that. And so this has been a big, that's kind of a big deal, because before we were always kind of scared of the FDA. And the FDA, so the feeling was, those of us in the stem cell arena, we can't really add or subtract much. We can take stem cells out, and in my case, it's primarily bone marrow. We can concentrate, but we can't really add or subtract. We can't do that, because then the FDA says, in so many words, becomes a pharmaceutical. We can't keep it out of the body longer than 24 hours. It becomes a pharmaceutical, in so many words. So this is really kind of it's a little bit of a earthquake in the whole landscape right now. So we don't know how this will settle out. Very interesting, though. You know, there's two camps. There's the bone marrow camp and the fat camp, adipose. Both have stem cells. Excuse me. I would submit that the bone marrow is probably got better scientific research behind it. So the adipose tissue, they're using stem cells derived from adipose tissue, it's legitimate. I just think the bone marrow is so easy. The bone marrow is so easily accessed, and the vast majority, the literature, scientific literature, really is heavily supportive of bone marrow aspirate concentrate instead of, as opposed to adipose. A lot of bad, unfortunately, in this arena, we've got a lot of bad stuff that's happened historically. A lot of stem cell clinics, even locally up here in the Seattle area, I know one chiropractic clinic was taking out full-page ads in the Seattle Times saying, hey, we got stem cells. What they were using was off-the-shelf, what we call perinatal products, amniotic fluid, Wharton's jelly, placental products. And there's a consensus statement that came out by people that are leading lights in this area across the country who said, these are not stem cells. There's nothing to indicate there are live stem cells in any of these so-called birth products or perinatal products. Bad Batch, if you're really interested, very harrowing discussion or storytelling about some clinic in California, kind of chiropractic clinic, and they hooked up with somebody who was making some stuff. People died, people got very sick, and basically motivated by greed, a bunch of bad stuff happens. So, that refers to the consensus statement that came out about 4 years ago, saying all these perinatal products are basically, to call them stem cells really is a bit of a stretch at best. There is, ASF has come out with guidelines for safe and effective responsible use for stem cell therapy. So, and I think that's a good idea. Moving on to interdiscal therapy. So we do have a number of things we've used in the, historically, fibrin adhesive, BMP, growth differentiation factor, which I'm not really sure what that is, alpha-2 macroglobulin or A2M, PRP, autologous mesenchymal stem cells, cellular therapy, viable allograft therapies. We're going to get into a little bit of that. Actually, Doug is much more of an expert in that area than I am, but we'll touch on that. This is so one of the complaints we get is, people saying, well, there's no research to support stem cell therapy. Really not true. There is plenty of research. This is a article by Tao that came out, basically meta-analysis. So you can see it took a lot of articles, almost 1,400 articles, and came up with this review that's, out of them, only 6. So the fact that a lot of these articles were, level 3, level 4, it's still evidence, right? I mean, in the hierarchy of evidence, 1 being the top of the heap and level 6 being kind of the bottom, it's still evidence. So as I showed you earlier, there's a lot of research going on, and kind of dismiss it out of hand that I've, patients see and they said, my doctor told me that it's all hocus pocus. Well, really not true. If anybody, if they really looked into it, there's a ton of research going on. This talks a little bit, as one Doug's slides here, talks about the prevalence of discogenic pain, how that kind of actually decreases over time on the age brackets. And then as we get a little older, we get more facetogenic pain in general. Again, this is proprietary endeavors by the industry, Mesoblast. This is a company that's come out that's looking for a ready-made stem cell that can apply to clinical situations. Bunch of ongoing trials. Again, I kind of these are Doug Beal's slides that he could go on forever. I'm just introducing the fact. Another one, viable allograft with Vivex. VAST trial, I think it's comparing a couple of these, like Vivex with mesoblast. And basically, they all kind of work. So, you know, that's the fact of, okay, what's going to be best? Now, there's a big difference between, you know, what I would call the proprietary. These are big companies with a lot of money behind them versus, you know, Mr. Smith who comes in. I tell him, you know, we could go that route. We could go with your own stem cells, which are probably pretty good. And the patients have been told, maybe they went to a seminar by one of these chiropractic clinics and said, no, your stem cells are too old. And I tell them, look, if you're sitting here talking to me, your stem cells are fine. Your body's making 1/3 of a trillion stem cells every day, most of them coming from your bone marrow, but also in your gut. So that's just patently false. So a lot of these studies that show, not really, doesn't really show up great there, but improvement in the signaling of the disc after treatment, improvement in the ODI basically, in these studies. Again, I'm just kind of using Doug's slides as kind of like just to touch on this stuff. So I'm a bone marrow guy, bone marrow aspirate concentrate. This article that shows that there's basically 41 surface antigens associated with MSCs. To me, that's like, hey, you're getting the whole package right with, if you do take the patient's own bone marrow and use that. So I'm not saying I'm right or they're wrong, but that's just, you know, to me, it's fairly straightforward and simple. You avoid a lot of issues. If I'm telling patients, I'm just taking stuff out of your own body and putting it to work where it needs to go, where you don't have enough stem cells, and basically put it to work. Very simple setup in our procedure room. You got the C-arm there. Hard to see, but there's a Jamshidi needle going to the right iliac crest there, fairly straightforward. Just oblique view, Jamshidi needle going in the iliac crest. Pretty straightforward. And most people say, you know, I think in med school they told us how painful bone marrow aspiration. Not really. If you do it right, not very painful at all. At least half the patients do it with no sedation whatsoever, and they do fine. That's kind of a depth view to make sure we're in the appropriate depth. My medical assistant Justin getting the stuff ready once we get the bone marrow. And so the current system, it's Zimmer Biomed system. We collect bone marrow aspirate concentrate, put it in there, and out of that we get the stem cells. Usually out of 50 cc's of bone marrow aspirate, we'll get 6 to 8 cc's of bone marrow aspirate concentrate, the stem cells per se. And then along with that, we'll get about 24 to 30 mLs of PRP, platelet-rich plasma, using that combination. I tell patients the stem cells are like the seeds, and the PRP is kind of like the fertilizer. Kind of a rough analogy, but kind of works. So we've got combination. This is again Doug Beal stuff going on here. He's working on something, interdiscal peptides, blocks TGF-1 beta 1, TGF beta 1. Again, interdiscal therapy using specific things, obviously not cellular therapy. So again, what's the magic bullet? You know, is it going to be cellular therapy? Is it going to be something like this? This product called Remidisc. In early trials right now, maybe phase 3 clinical trials. Yeah, 2B, I guess. Obviously, there's some promise in this area. I'm just not. I know that I'm aware of these kinds of proprietary products out there. I just can't, you know, I'm not an expert by any stretch. Going forward, all kinds of talks about things called exosomes. Exosomes are like people liken them to little emails going out from the stem cells to the surrounding cells to tell them to go to work. Here's your marching orders, or here's your construction orders to go. So a lot of companies are focused on exosomes. I'm not sure whether that is That's part of the future, who knows? One of the problems is everybody's got their own little recipe, right? I follow Steve Centeno in Denver, Regenix. He's been doing this for probably 15 years. He's kind of a leading light, but he's also very much, you know, his idea is like, I'm the best and everybody else is a fraud. He has a lot of useful information, but so you're in this space because it's not covered by insurance, right? So there's a lot of, it's basically money, you know? So he's trying to he has a clinic he has a clinic offshore, I don't know, Bahamas or Cayman Islands or someplace where he can also do some stuff where he's not restricted by the FDA. So that's a big problem. We got all these people doing their own little recipes. So uniformity is hard, right? You know, what's going on here? Everybody's doing their own little, that's just, you know, usually that's not how medicine works. You know, we share information, we have standards, we have definitions of what is, you know, what certain things are. So that's, you know, I see that as a big problem, to be honest. So third-party reimbursement, not happening right now for the most part. Once in a while, we get somebody who'll pay or pay in part for stem cell injections. Regulatory concerns, always there, referred to the Bernal decision. I think the big thing is just, you know, doing what's right for the patient, you know, and just that's what I try to do in my practice. And I've actually had patients get upset with me because I told them that I don't think stem cells is a good idea. I said, I think you should save your money and go get a hip replacement or whatever. So I think it's, you know, just trying to keep that in mind. I don't know if we got any more. Are we kind of locked up here at the end here? Maybe. Oh. So I wanted to bring this picture up. You know, you guys are familiar with pickleball at all? You're probably too young, but this is like in the 60-plus age group, this is a big deal. Pickleball is huge. It started actually in Bainbridge Island, like in the 1960s, and it's spread across the country, probably the world at this point. Anyway, the reason I bring this slide up is I have recently, an orthopedic doctor came for stem cell, and we came to the day we're actually doing the procedure, and this is a fairly prominent orthopedic doctor locally in the Seattle area. And you know, as we're talking, we're getting ready, and I said, well, so as I understand, you did a lot of hip replacements and knee replacements in your career, but yet you're here with me getting stem cell for your knees. I mean, what's up with that? And his answer was simple. He says, I love pickleball and I love skiing in the wintertime, and I want to keep doing that. That was kind of the end of the conversation. Take that for what you will. I mean, it's not like, and I'm not anti-joint replacement. Like I said, sometimes I tell people, look, you need to go get this done. The stem cell won't help. But it's kind of interesting. He actually kind of looks like this guy that I got on this. This is not him, but it kind of looked like him. This is an interesting case where we had a patient who was in an automobile accident at the age of 7, spent like a year in the hospital, according to this is his story. He had, among other things, he had elbow fracture. Never really, so he had a kind of a, you could tell he had kind of a shortened right upper extremity from whatever, probably from the fracture and some shortening as a result. Obviously some long-standing arthritis. He was coming to us like, hey, can we help? He had all kinds of stuff that you can name. Actually had an ulnar nerve transposition surgery, which did absolutely nothing. I'm not sure who recommended that, but so he came. We did, so I said, I don't know, this has been going on for 50 years, and we did a test injection, anesthetic, pain went away. I said, this is a reach, but, we could do this. So he had stem cell injection. And lo and behold, 6 to 8 weeks later, he's noticing improvement. So, this is something that happened 50 years ago, okay? That's kind of remarkable, right? So he has decreased pain, not pain-free, But decreased pain, improved range of motion on a situation that happened 50 years ago. I find it kind of remarkable. I was not hopeful at all, but yet, you know, you see these things that continue to amaze me. Same thing, this is a person with bad arthritis in their hands. You can see the hardware there, a lot of, you know, multiple surgeries. Now has CMC arthritis going in right here. That's about the only joint that hasn't been like fused. And she was looking for alternatives, you know, like, do I really want another surgery? This lady did remarkably well with stem cell injections. And again, maybe not pain-free, but dramatically reduced pain, improved functionality. So for her, it was like a godsend. Same person, other side. We are now partnering with a company called Biologics. We're following each of our patients. They're enrolled. This company called Biologics is started by a couple of doctors who were doing regenerative medicine and, you know, dealing with the same issues. You're like, you know, how do we get useful data? And so they came up with this. They basically started a company where we track all of our patients. The patients, once they're enrolled, they become basically part of a database. They get text to report their outcomes, all fairly seamless from our standpoint. Now, this is what it's got to be, right? Those people that are working in this field, we have to develop the data. Without the data, you know, it's still going to be a hard sell to medical people, insurance people, the public at large. So I'm very happy that we have this relationship with this company. So little comment here. You're not going to get, if you go into this space, you're not going to get referrals from your family doctor or your, most time, not your orthopedic or physical medicine. I mean, it's just not going to happen. To me, it's a direct to consumer process, okay? So you have to be able to, you know, have some resources to go in that direction. Currently, I have a call-in radio show called Conquering Your Pain with Dr. Dan Nelson with my co-host Jerry Berg every Sunday morning. We used to have it at Saturday, which is actually better, but then the pandemic hit, and then we stopped it, and then recently started back in April. But that's just one avenue where, you know, I see it as almost a public service because we talk about I don't talk about just stem cell, I talk about interventional pain medicine because I think we haven't done a great job as a specialty getting the message out. I get patients all the time, and you will see this too in your career. Doctor, I wish I'd met you 10 years ago. You know, I wouldn't have gone through all this stuff. And, you know, half their time they're coming from a practice where I know I've gone to the practice, I've done lunches, I've met with the doctors, and yet, I don't know, there's still a disconnect. So anyway, you know, we need to do a better job of getting our message out of how we can help people. Oh, this is my new slide deck coming up. I'm just a work in progress. So instead of the previous thing, well, I'm just, you know, any comments would be welcome, I think, just to change up the cliche side to something else. So thank you for your attention. I'm going to do a shameless plug for my favorite charity, Climb for Captives. We raise money for victims of human trafficking around the world. My friend Jeremy Valoran there in the lower left, well, he's on. This is the guy who started this back in 2004. They were playing Mount Rainier with a bunch of guys, and they said, hey, we should do something worthwhile. It was 4th of July. They said, Independence Day, let's raise money for people who are under some sort of bondage worldwide. So now it's a worldwide organization. He's spoken around the world. He's been invited to the Vatican as an expert in this arena. And this is, anyway, they just changed their name to Atlas Free, no longer Rescue Freedom, but if you Google that. This is me on Mount Hood on my 60th birthday. I'm telling you, that is fact is me. What I don't recommend is that you go with a group where the average age is about 25 years younger than you. That's a little bit hard, but anyway, that's pretty much it. So I'm hoping there's some questions out there. Yes, sir. Do we have a mic?
So thanks for the presentation. It was really informative. How do you prevent against lateral femcutaneous nerve injury when you go for the grafting? Or is that unavoidable sometimes? Or is there a way to like never do that?
To never do, I'm sorry, I didn't get that.
To never hurt the lateral femcutaneous nerve, which is right around the iliac crest?
Yeah, lateral femcutaneous would be more anterior, right? I think what you'd be more concerned was like middle inferior cloneal nerves, because the lateral femcutaneous might come over more anterior. It's a concern. I honestly never had that be an issue. In fact, the other day I was doing, it's funny because we did one yesterday, and that very thought came to mind, and because if you ever seen a patient who's had a bone graft with harvesting from the iliac crest, for like an ACDF or something, they complain more about that pain than they do about the surgical site pain in general. We've never had that. We never had that happen. So great question. Just the beauty of this is there's no major nerves, blood vessels, anything usually in the way of what we of where we're working.
So I'm a spine surgeon, and hitting the cloneal nerves is an old school problem, not a modern problem. The lateral femoral cutaneous goes below the anterior superior iliac spine. It's an anterior structure. Dan's talking about harvesting from the posterior iliac crest. The cloneal nerves come right across here, and they go out into the buttock. And if you make a semicircular incision to drop down on the iliac crest, you will get the cloneal nerves. And that's old school surgery technique. What Dan's doing is he's going through a puncture wound. So the statistical probability of hitting that nerve, if you make an incision and just take a forceps or a clamp and spread it, the nerve will be out of the way. You drop your Jamshidi right on your target and you go in. So the consequences of downside iatrogenic injury in this technique are diminishingly small, but in open surgery, posteriorly, they're more of a concern, but not in what we're doing here.
Cool, thank you, Neil. Another question right here?
How much you're harvesting and what you get out of it after you spin it down?
Yeah, so with our...
The question was, can you repeat how much volume you're harvesting and also how much volume of the residual PRP and stem cells you're getting after you spin it down?
Right. No, so with our current Zimmer Biomat centrifuge biologics system, where we take 50 cc's of bone marrow aspirate, and we're putting that in. It takes about 20 minutes to process that. Out of that, we'll get 6 to 8 cc's, mLs, whatever, of bone marrow aspirate concentrate. That's the stem cells. That's the nucleated cells that we're calling stem cells. And anywhere from 24 to 30 mLs of PRP. And then we'll use that combination depending on, like if I'm doing a knee, I'll do 1 to 2, 1 ml, or the ratio would be 1 to 2 of stem cells to PRP, just kind of depending on what the target is. Usually we have plenty of PRP and we have some left over. Sometimes I have a little residual stem cell left over and usually more PRP. And I give that back to the patient IV. I mean, I tell patients, there is some evidence that stem cells intravenously do have some homing capability. I figure, hey, what's it going to hurt to give whatever little bit we have left, slow IV push. Never seen a problem with that. But yeah, so about 68 cc's of stem cell, 20 plus cc's of PRP. Yes.
Thank you. Thank you for the talk. 2 questions briefly. The first is patient selection. What can you tell us about that? Are there guidelines in place? For instance, like with neuromodulation, SCS, how I created a space. With failed back surgery syndrome, do we use this post-op or more like a surgery sparing technique? So that would be the first question. And then the second question, what do you think needs to be done from a regulatory standpoint? It seems like there's definitely some promise to this type of treatment. I don't know if you saw, I think the Mayo Clinic recently had a paralyzed individual walk again after they had injected some mesenchymal or stem cells into the spine. And that was a first, it sounded like. So there's a lot of potential. How do we regulate it? Should there be, for instance, that company that you mentioned, should they be evolving into a regulatory body, not necessarily to monopolize the market, but more to set standards? How do you see the way forward?
Yeah, no, a good question. So the first one I've had a little hard time hearing the first part, but it's just how do we present this as in the scope of other treatment options, or?
The initial question was around indications, what populations, what cohorts, how do you identify an individual who's ideally suited?
Right.
And then secondly, what regulatory mechanisms would be reasonable?
Right. So, identifying the patients, these are patients typically with arthritis, and they may or not be a candidate for like joint replacement, or, they come in hand arthritis, foot and ankle. And they've had, maybe they've had prior surgeries or prior joint replacement, and they come in expressing a desire to avoid joint replacement surgery. Okay, so that's one of it. But an arthritis situation, I think at least worth a discussion. Obviously we don't just offer that. If somebody comes in for knee pain, for example, because they think, oh, hey, I've got a problem with my knee. I mean, I can't tell you how many times I've done the full workup and tell them, look, you got some issues in your spine that's making your knee pain worse. Maybe you got some arthritis, but you got some radiculopathy that's probably amplifying. So we need, there's been many times where I've done the full workup and say, hey, yeah, maybe you got some knee pain, but you got spinal issues as well. I think we need to address those maybe first and foremost before any discussion of stem cell. So it's really, in my mind, it's a balanced discussion. It's you guys heard, I'm sure you guys you heard of the Yo Mama rule? No? The Yo Mama, this goes way back. Don't do anything to a patient that you wouldn't do to your mama, okay? That's basically how it works. You can keep that in mind. Hey, would I do this on one of my family members? Yeah, I think I would. Then you're probably okay, So, there's lots of times where if you're going in with a little microscope and focused on the stem cell I'm always worried about what else is going on. And that's, as an interventional pain specialist, that's what you should be doing. You should be going through the list of, okay, well, what else could be causing this pain? That's part of the due diligence, just going through, okay, what other pain generators are in play, and can we rule out or rule in before taking this patient down the stem cell path. I think that's absolutely essential. I see this all the time. I see patients who have gone to other stem cell clinics and had exact things done, like stem cells for the knees, and with total bust. Like, you've got spinal stenosis, you got radicular knee pain, lower extremity pain. You didn't stand a chance, basically. You got misdiagnosed, basically. So I see this all the time. On a regular basis, I see the misapplication of so-called stem cell therapy. So the next question, regulatory. I mean, that's a big area. We don't know. How do we I mean, this Bernal decision was kind of a setback in some ways. In some ways, I think it's good. In some ways, it's bad because I don't want to see all these fly-by-night operations going out doing, you know, chiropractic clinics hiring a nurse practitioner to do stem cell injections. That's absurd. I mean, I've seen cases where the person doing the procedure, from what I can tell, shouldn't have been allowed to hold anything sharp in their hand. I mean, that's the conclusion I come to, you know? So, yeah, this is a difficult, you know, I'm not a big government oversight guy, but at the same time, you know, we got to police ourselves for sure.
Any other questions? All right, we're going to move on to the lab. Dan, thank you so much.
Thank you.